Okay. Thank you so much to the East Portland Rotary Club for the invitation to talk about something that I'm really passionate about. And I hope to have an open discussion. If you have questions in between, don't hesitate to ask them, because the goal here is to talk about heart disease, some things that you might already know, some things that might be new to you. And Jeff had asked that I talk about some things that are new in cardiology. And so I'm going to try to intersperse some things that are currently being practiced and are relatively new to the field of cardiology. Okay, so I'm going to go ahead and share my screen. And okay, let's see. I'm going to go ahead and okay, so my objectives today are to give an overview of cardiac structure and function, describe the different facets of heart disease, and provide updates in the field of cardiology. So you guys are probably all aware that heart disease is the #1 cause of death worldwide. And although ischemic heart disease or coronary disease is the #1 cause, stroke, heart failure, diabetes make up even more of the global deaths that we're seeing because of cardiovascular disease. This pie chart helps break down, the causes of heart disease. What we think about most often is the blue part of the chart, which is coronary heart disease. However, it's important to remember that stroke, heart failure, high blood pressure in itself, other arterial diseases, valvular disease make up a significant segment of this pie chart as well. The way I like to break it down is to talk about the fact that the heart is like a house. And the reason I bring up this analogy is because oftentimes when I see patients in clinic, what I ask my patients, about their family history, because family history is important when we think about cardiovascular disease. And oftentimes they'll tell me that their mother, father, sister, brother has a cardiac condition. And I'll ask them, can you tell me what kind of cardiac condition? And they've never probed further to think about what kind of cardiac condition they might have. And as we gain more appreciation for the genetic factors that play a role in cardiovascular disease, it's important to really ask the questions in terms of what type of heart disease we have and what kind of heart disease our family has. And so in order to help simplify that, I compare a heart to a house. And I think of it as a 4-chamber house or a 4-room house. And just like your house, when you call someone for a problem in the house, you don't say, I have a house problem. You'll say, I have an electrical problem, or I have a plumbing problem, I have a structural problem. That's the same way I think it's important to break down the causes of heart disease. Just like your house has a basic structure, the heart has the basic structure of 4 chambers, 2 on the left side, two on the right side, and you can get problems with the structure of the house that can lead to what we call a cardiomyopathy or heart failure. However, there can also be problems with the electrical signal of the heart, the same way as your house, and so you can get cardiac arrhythmias. You can have problems with the doors or windows of the house. Same way in the heart, you have valvular heart disease. And just how you have plumbing problems, we can have problems with the major vessels of the heart, as well as the small coronary vessels, coronary arteries of the heart. And this is the plumbing of the heart that can have problems. So when you think about heart disease, remember to keep a broader perspective, because heart disease is multifaceted. So the first thing I'm going to talk about is coronary heart disease. And I think this is something that most people are familiar with. but I'm just going to give a brief overview so all of us are on the same page. So when we think about coronary artery disease or coronary heart disease, what we are talking about are the blood vessels that lay on top of the heart. So as the blood leaves the heart through the aorta, which is the major blood vessel of the body, the first vessels to come off are the coronary arteries. So the heart always feeds itself before it feeds the rest of the body. So it oxygenates itself first. So these are just basically vessels. So these are just like the plumbing in your house. So these are small vessels that can develop plaque, the same gunky stuff that you can see in the plumbing in your house. So you have a normal blood vessel, and then over time you can get plaque buildup in these blood vessels that, if they accumulate slowly, can slowly cause a decrease in blood flow and symptoms that we consider angina. So angina just means that the heart is not receiving enough oxygen and it's giving you a signal. And often that signal is chest pain, but that signal can be shortness of breath, that signal can be jaw pain, that signal can be arm pain. So the body is giving us a signal that every time the heart requires more oxygen, the blood vessels are not able to supply it because there is obstruction to flow. So this is stable coronary artery disease that develops over time. This is in contrast to acute plaque rupture, or what most of you will know as a heart attack or myocardial infarction. So this is where one of the plaques, and it can be at any stage of that plaque buildup, where the cap that covers it ruptures, there is clot formation, and you have sudden, complete obstruction to blood flow. That's what we call a myocardial infarction. That's a sudden onset of a problem, as opposed to this stable anginal symptoms that you can experience when that plaque buildup happens slowly. Our current practice to treat coronary artery disease is often stenting. So stenting is where we put a catheter through the blood vessel that we know has plaque buildup. We open it up with a balloon, and then we put a metal mesh in there that basically pushes that plaque to the side, opening enough the blood vessel enough for blood flow to be restored. And this is very satisfying to see on coronary angiography. People often feel better. They feel like they can breathe better. Their chest pain improves. And so it can provide immediate results. In addition, we sometimes use bypass, where we completely bypass the blocked vessel with another artery in the body. And as you can see on the right, this is the most common used graft. It's called the lima. It's coming from one of the blood vessels of the main arteries and is being used as a bypass vessel to the coronary, the obstructed coronaries. So when you talk to your family, you might hear that they've had stenting, and that's this more this procedure where they had stent placed versus bypass, which is a more invasive surgery. I think it's important to remember that plaque doesn't develop overnight. So you can get plaque rupture that's sudden, but plaque buildup happens very over a long period of time. And up to 1/3 of young adults on autopsy specimen have been found to have plaque buildup in their blood vessels. So it's a problem. It's a problem that can arise early, but the one thing to remember is that it is a problem that is largely attributed to our risk factors and how we lead our life. And so lifestyle interventions can significantly improve the rate of buildup in these blood vessels. So when we think about risk factors, so when when we started studying this as a community, a medical community, we understood that this is a problem. So coronary heart disease is a problem. Plaque is building up in the blood vessels. So then the goal was to determine what are the factors that increase someone's risk for developing this plaque buildup. So we think of non-modifiable risk factors, so things that we cannot change. Our age, our family history, our race, things that can influence the risk of heart disease, but are non-modifiable. On the other end of this spectrum are things that are modifiable. On the right, you see smoking, physical inactivity, diet, and weight, which are things that we can easily adjust in order to reduce our risk of coronary heart disease. On the bottom are the three major disease processes that lead to coronary heart disease, and these need to be controlled in order to reduce our risk of coronary heart disease. So what I hear sometimes is, look, it's in my genes, it's inevitable that I'm going to have heart disease. And it is true that heart disease can run in the family, and if you have certain genes, you are at higher risk for developing cardiovascular disease. However, it's important to know that even in people who have higher risk of cardiovascular disease, favorable lifestyle improves that risk. So if you look at the three categories listed, low, intermediate, and high genetic risk, and then the red is unfavorable lifestyle, and blue is favorable lifestyle. And no matter what your genetic or underlying risk is, a favorable lifestyle can improve your risk of having cardiovascular disease. The American Heart Association has put up a campaign called Life's Simple 7. It's to help people understand what an ideal cardiovascular health lifestyle looks like. So what does it mean to have ideal cardiovascular health? And it's these 7 factors, not smoking, being active at least 150 minutes every week, controlling cholesterol, managing blood pressure, eating healthy, losing weight, and reducing blood sugar. And this website helps provide guidance to each of these factors and what numbers you should be achieving, what you should be eating to try to achieve eating health, like what does a healthy diet look like? And so it really breaks it down very nicely. And so it's a great resource for you, for your family. I use it for my patients. So what's new? So I think a lot of that is known, what is new in terms of coronary heart disease? So I think of some of the newer things in terms of coronary heart disease is the understanding that there is much more that we can't see that really can influence blood flow to the heart. And what do I mean by that? So the diagram that I originally showed you that showed the blood vessels laying on top of the heart. And we think of 3 major blood vessels. And this diagram is based on what we see on angiography. So angiography shows us the major blood vessels. So that's what we use as our framework for what problems need to be fixed. But as we are better understanding the whole coronary circulation, we realize that it's much more complex than that. So this diagram depicts all the small vessels in the heart, and it's not as simplified as what the current the dogma that we use. So you can see that there's a lot of smaller blood vessels, and what we're realizing is that these smaller vessels, or the microvasculature, actually has more to do with the blood flow in the heart than these larger blood vessels that are just basically capacitance vessels. And so the problem with that is that our current diagnostic algorithms don't necessarily help us look at these small vessels. So if we do an angiogram, we can only see the big vessels. We can't assess the small vessels. Since we can't see them, we have to assess them functionally. Are they working or are they not, rather than looking to see if they're blocked the way we do on angiography. And so as we are refining our tools to better understand whether or not this microvasculature is working, we will see treatments coming out specific for microvascular disease, and hopefully be able to treat people who in the past have been written off as non-cardiac chest pain, where we are realizing that that's not true. What we previously thought was non-cardiac chest pain could be cardiac chest pain due to the small blood vessels of the heart. In addition, what we're finding is that our current treatment algorithm may be a little bit aggressive. And what do I mean by that? You know, typically you go to a cardiologist and you see, they do an angiogram, they find a blockage, they fix it. The cardiologist is happy, the patient's happy, everyone's happy. However, this stenting procedure that we do hasn't really been tested against control. So we know that stenting works in the sense that it improves angina, but as we are testing it against our medical therapy, what we are realizing is that in stable disease, not in unstable, not in the setting of a myocardial infarction, in that setting, stenting still has a very strong and robust role in helping save lives. However, in the stable setting, we are learning more and more that medical therapy can likely serve the same purpose as coronary stents, even in patients with major blockage. The idea being that atherosclerosis is likely a systemic problem, and fixing one small portion of the circulation isn't going to fix the larger picture without treatment of the underlying risk factors that I mentioned. You know, making sure that the cholesterol is really well controlled, making sure that the diabetes is really well controlled, having people on statins, having people on aspirin. This we know can really, really improve outcomes and prevent heart attacks, improve symptoms in a way that we only thought stents could do in the past. So I'm going to shift gears now. So I was talking about coronary artery disease, so the plumbing in the heart. So now what I want to talk about is heart failure. And the reason why I think this is so important is because it doesn't get as much press, but it is a growing problem, and it is going to be a worsening epidemic as we learn to treat coronary heart disease better and better. So people are living from their heart attacks, and they're developing, some are developing heart failure. So let's go back to the basics. You know, what is the function of the heart? I mentioned the structure before, that it has 4 chambers, but what is the point of the heart? It is a pump, right? So the purpose of the heart is to pump the blood. Why blood? Because the blood carries the oxygen. So the heart pumps blood to the body uses the oxygen, returns the blood, the heart pumps it to the lungs to get more oxygen. It comes back to the heart, it pumps it back to the body. So really it's serving as 2 pumps. One pump that's pumps blood to the body, the other pump that pumps blood to the heart. I mean, to the lungs, I'm sorry, to get oxygenated. So to the body, and the other side pumps it to the lungs to get oxygenated. And that's depicted in the second picture, that the right side of the heart receives the blood without oxygen, and that's why it looks blue. And that's one of the pumps per se. And the second side is the left side of the body, which receives the oxygenated blood and pumps that to the whole body. The other term that I want to just make you familiar with is the idea of systole and diastole. And you probably have heard of this in terms of blood pressure. What is the systolic blood pressure? What is the diastolic blood pressure? But I want to use it in terms of how we think of heart function. So systole is when the heart is squeezing to get the blood out. Diastole is rest, and that's when the heart relaxes to allow blood flow to fill. It's important that the pump function the pumping as well as the relaxing are both working well in order to have appropriate cardiac circulation. I just want to familiarize you with a term called ejection fraction. And anyone who has ever had an echocardiogram has probably heard this term, ejection fraction. Ejection fraction is basically the amount of blood pumped out of the left side of the heart over the amount of total blood. So it looks at how much total blood is in the heart and how much is pumped out.
Right.
Our overachievers, then they want an EF of 100%. However, that's not how this works. So normal cardiac function is considered an ejection fraction of above about 55%. So where can it go wrong? So the heart, I mentioned that there's a squeezing function and a relaxing function. So the heart failure can develop when the squeezing function is compromised or when the relaxing function is compromised. So what does this look like? So if you think about the relaxation of a heart, think about a rubber band, right? So a really thin rubber band is very pliable and can open easily. This is exactly the way the heart functions when it is healthy. It opens up, allows blood flow to come through, allowing it to pump out a lot of blood. If the heart becomes stiff over time, whether that's due to high blood pressure, whether that's due to obesity, or other problems that can happen with the heart muscle, what happens is it becomes stiff. It becomes like one of those really thick rubber bands that don't open. And so as you can imagine, it doesn't open very much. The heart doesn't open. And so it doesn't fill and the heart doesn't pump as much blood as the body needs. This is in contrast to systolic heart failure. Think of it as a balloon. So you think of this as a really big baggy balloon and that has lost its elasticity. That's what can happen when the heart becomes weak and dilated. It just can't pump the blood back the same way as a big baggy balloon cannot. And either of these problems, a problem with the pumping function or a problem with the relaxing function, can cause heart failure. So what are some factors that lead to heart failure or a problem with the pump function? I mentioned a couple: diabetes, hypertension, obesity, but also coronary artery disease. So if there's a problem with the blood flow, you lose blood flow to a certain part of the heart, that part of the heart dies, and now the heart is going to lose some of its pump function. And valvular heart disease, I'm going to talk about in a little bit. Just a second. So when we think about heart failure, we think about it in stages. Stage A being the least severe and stage D being really advanced heart failure. And you can see that survival really depends on how severe the heart failure is. Really late stage heart failure can actually rival the prognosis of really advanced malignancies. And so the prognosis can be really severe. So what are the symptoms of heart failure? And I think these are important to know because it's often missed, okay? And you hear a lot of stories of things being written off as something else, whereas cardiac problems are not considered. So shortness of breath. If someone is being diagnosed with asthma really late in life, it should be a diagnosis of exclusion. You should look at the heart first. So if someone has new wheezing, shortness of breath, and cough, the assumption should not be that this is asthma. It should really be evaluated for a cardiac issue as well. Swelling of the feet and legs is a cardinal sign of heart failure. Difficulty sleeping because you keep waking up short of breath. Sudden changes in weight. People can present as just chronic lack of energy. So any of these symptoms can really be a manifestation of a weak heart. One other one that I want to mention that is very common is arrhythmias. So atrial fibrillation specifically can be the presenting sign of heart failure. Atrial fibrillation is the most common cardiac arrhythmia as we get older. You probably know someone who has atrial fibrillation, and what it is a disorganized electrical signal. So normally the heart is very rhythmic. The top chambers pump, the bottom chambers pump. Top, bottom is very rhythmic. What happens in atrial fibrillation is you have a disorganized signal that makes the heart beat really fast and can cause people to feel their heart racing, can cause shortness of breath, and can actually cause weakening of the heart muscle. When we think about heart failure, the presentation can vary significantly. There are people who have class 1 symptoms. That means no limitation in physical activity. So they have heart failure, but are able to do all their regular activities, versus people who have class 4 heart failure, who are unable to do any kind of physical activity without shortness of breath, even shortness of breath at rest. And so as you can see, heart failure can be a really significant, can have a significant impact on quality of life. And that's why it's important to diagnose it and treat it so that patients can get relief and improve their quality of life. How is heart failure treatment? The first line is getting rid of all this extra fluid. As the heart's pumping function is not working, blood backs up, fluid backs up, and you get problems with weight. The weight starts going up significantly. So you got to get rid of that weight with diuretics. You got to limit sodium intake, because sodium attracts water. It makes the body retain water, which is kind of the enemy of a patient with heart failure, because the heart is already not pumping the way it should. And then medications. You may hear the term goal-directed medical therapy. That's the idea that we are using medications to try to improve cardiac function and keep people out of the hospital. So what's new in heart failure? I think it's really important to know that we have excellent medications to treat heart failure now. That really poor prognosis that I had mentioned before is changing over time as we understand what medications are beneficial. We are seeing people live longer, be less symptomatic, and keeping them out of the hospital, to the point where this diagnosis or this term heart failure is being reevaluated. In the past, heart failure was almost a death sentence, and that's why it was called heart failure. But now we know with the right medications, it can be properly treated and people can do really, really well. And so now that term heart failure, which is very scary as a new diagnosis, is being reassessed. The worlds of cardiology and endocrinology are colliding. And what do I mean by that? So the newest kids on the block in terms of heart failure treatment are actually diabetes medications. So diabetes medications are now being used to treat cardiac conditions, even in patients without diabetes. And so cardiologists are having to become familiar with a lot of the diabetes medications, because we are finding that they can really improve heart failure symptoms and the prognosis associated with a heart failure diagnosis. You probably may have heard of, assist devices or ways that we can sustain the heart. One of the ones that you may or may not have heard of is called left ventricular assist device. This is basically where a machine takes over the pump function of the heart, because the heart is no longer able to do this. This is used as a bridge to transplant until patients can get transplant therapy, or sometimes it's used as what we call destination therapy. People use this to keep their symptoms at bay and keep them out of the hospital because they're not candidates for transplant. I mentioned cardiac transplantation. So this is where basically we use a donor heart to replace a patient's non-functioning heart. You may have heard some press about a pig heart being used recently. That's not ready for prime time yet. Right now, it's just human hearts that are used for donor transplants. And the third concept that I want to discuss here is valvular heart disease, because again, this is not something that gets a lot of press, but I think is important to know, especially as we get older, because is more and more likely that someone you know is going to have a problem with their heart valves. And again, as I mentioned before, the valves of the heart are like the doors that open and close. Their job is to open to allow the blood to fill, and close and not let things leak, the blood leak back. So stenosis is on the left side when the valve becomes stiff. So if you look at the bottom left, you see a normal opening aortic valve. It opens up, there's a lot of space for the blood flow to go through. Stenosis on the top is where that valve has become very stiff over time and is not opening the way it should. This is called stenosis, and this can happen with any of the 4 heart valves in the body. This is opposed to leaking, where the heart valve isn't closing. So you can see on the bottom right, a valve that's closed really nicely. You can see that there's very little room for blood to flow back. Whereas the top right, you can see that the blood, that it's not closing properly. And so there's a lot of room for the blood flow to leak back. And this is another visualization of that, where the left is where the valve is closing normally, and the right is where the valve is not closing normally. And you can see that there's a lot of blood leaking back into a prior heart chamber. So this is where there's probably been the most advances in cardiology recently. So if you look 10 years ago, we were all, anyone who needed a valve replaced was getting open heart surgery. This is a major surgery because you have to have a sternotomy, a scar, the chest is opened up, and the old valve is cut out and the new valve is placed. However, the world of cardiology is shifting towards what we call transcatheter valve replacements and repairs. So what does that mean? That means instead of opening up the chest, the procedure is done completely through the blood vessels of the body. And so the aortic valve replacement, this technology has really taken off. And as you can see, so this is a graph of the types of valves that are being replaced. And the orange one are these transcatheter ones, and the SAVRs are the surgical ones. So you can see the blue line is actually dipping, whereas the transcatheter ones are just exploding. We are doing so many more of these transcatheter procedures and much fewer of the open surgical procedures. So this is a big shift in cardiac care that's happened over time. So the recovery with this open procedure can be, 6 weeks, up to 6 months. Whereas these TAVR patients are leaving the hospital the next day or the day after and resuming regular activity pretty quickly. Obviously, the type of valve has to be a discussion with your provider to see what the best choice is, but this is an area in cardiology that's absolutely exploding and changing really every year in terms of what options are available. So we talked about the aortic valve. That's ready for prime time. We're doing so many of those now, but new to the field are, and currently under clinical trials, are transcatheter mitral valve replacement. So this is where another one of the valves is replaced through the vessels and not through an open procedure. Currently, most people still get the open procedure, but I think in the next 5 years, this very well could be the standard of care. Other things we do are mitral clips. So these are this is a little clip procedure to help reduce the leaking. So you can see it's basically like a little clasp that goes and grasps the valve leaflets and closes it in order to prevent the leaking of the valve. And this is an option that is being used already and has been shown to be beneficial in patients who cannot get the open surgery. Obviously not for everyone, there's very specific candidates, but as you can see, the technology is changing really from surgical interventions to these transcatheter approaches. And one of the ones that is currently like gaining excitement too is this Ross procedure. So we just talked about replacing valves, your current valve with, we currently replace them either with metal valves or mechanical valves or bioprosthetics. So they're coming from pigs or cows. And they are all, they all can have a lot of wear and tear over time because they were not meant to be in humans. However, this Ross procedure is really good for young patients who need to get a valve replacement. And you're basically just swapping. The diseased valve is removed. Another valve from your body is being put in the aortic position, and you're getting a graft from another human to replace in one of the other positions. And this is good in the sense that the thought is that this is going to have less wear and tear over time. It is your own valve that is moving from one place to the other. The goal would be that the replacement valve that's coming from another human is actually going into a position that doesn't get a lot of wear and tear, and so should last a lot longer. So this is something that we're currently starting to do more of, especially for younger patients. So I just wanted to, I have a few more things that I can talk about, but I want to have some time for questions. But the idea that I wanted to bring today to the table was that heart disease really represents a myriad of different problems. And so when you get the diagnosis, or if a family member gets the diagnosis, to really understand what part of the heart is being affected, because it affects treatment, it affects, with some of these genetic problems, it can really have an impact on other family members. And the field of cardiology is advancing quickly with significant changes, especially in the field of valvular heart disease. That's where the biggest changes are happening. Heart failure as well, especially with medications, these medications that are coming on the market that are really changing the quality of life for patients with heart failure, as well as the long-term prognosis for these patients. So I think it's really an exciting time for the practice of cardiology.
So Dr. Sanhavi, why don't you stop your screen sharing?
Yes, let me stop share. Yes.
There you go. And I think we have time for one or two questions. Are there any? Jack, loud, please.
There's been a lot of controversy lately with the use of statins. Some people are saying that it causes problems. Others say there's no problem at all. What's your sentiment regarding that?
Good question. Okay, so the controversy surrounding statins, that's something that we deal with a lot in clinic. However, the controversy is actually really, there isn't controversy in the cardiology literature. Okay, the cardiology literature is very clear that statins help prevent heart attacks and prevent recurrent heart attacks. So people with established cardiovascular disease, there is clear benefit, and it reduces the risk more than any other treatment that we have. Okay, so from the cardiology literature, that is clear. However, what we find is that in the lay press, there is a lot of bad press around statins. And that comes from the symptoms that some people get on statin therapy. Okay, the main symptom that people notice is myalgias, so muscle aches, or some people notice joint pain. And then some people are scared to start statins because there's a small increased risk for diabetes. But let me break that apart. So in the trials, okay, despite the slight increase in diabetes, there is clear benefit in terms of reduction of cardiovascular disease. It is absolutely shown across multiple trials, multiple statins, and we think it's a class effect. So the symptoms, that comes up all the time, okay? And I think there was a very elegant study that was done that looked at the same patients. They were given 3 sets of pills. So, or they were broken up to 3 time periods, okay? The first time period would be they were on statin therapy. The second time period, they are given a placebo. So they're told it's statin, but it's actually not statin therapy. And the third arm of the study, or the third phase of the study, was no medications, no placebo, no sugar pill, and no statin therapy. And they randomized patients to being on different things at different times. What they found is that the amount of muscle aches that patients had were the same on statin therapy and the placebo, whereas muscle aches went down markedly when they were taking no medications. And what that showed is that there is what we call a nocebo effect with statins. So the idea being that placebo, everyone understands, a positive response to having a placebo, right? So you're given a sugar pill, but you think it's something, so you feel the benefit of it. Nocebo is where you take a pill and you think it's going to be harmful, and so you feel the harmful effects that you are expecting to experience. And so in all the studies, they've shown that the amount of muscle aches that people have is equivalent in studies, in patients on statin therapy and off statin therapy. However, I will tell you from my practice, I have patients who cannot tolerate high dose statin therapy, 100%, okay? And I am very mindful of that, but almost always I can get them on some dose of statin therapy. And people can have significant reductions in their cholesterol levels, even with even twice weekly dosing of rosuvastatin or Crestor, where they couldn't tolerate statins before. I've had patients who have not been able to tolerate statins for 20 years, who on appropriate low dose therapy are able to tolerate it with significant reductions in their cholesterol level. So I understand that there is a big discrepancy in what we understand in the medical literature versus what is in the lay press. I believe the symptoms can be very real, but understand that there are ways around it if needed. And there are alternates to statin therapy. People who can't tolerate statins, there are other treatments options that are now available as well.
So Dr. Sanhavi, thank you. We're probably about out of time, and I suspect that some of us are way too familiar with some of the things you talked about because we're living with some of those things. But we really appreciate your presentation and your being with us today. So thank you again.